Good afternoon or good evening. It depends on where you are. Eventually, good day if you are going to assist to this webinar in another time. We are going to discuss in this webinar why so many patients after BPH, BPE surgery maintain medical therapy despite the surgery. And this is an important point because what we expect from the surgery is to relieve obstruction and male LUTS. But in many cases, this is not the case. My name is Francisco Cruz. I will be the moderator of this webinar, and I live in Porto. And as faculty members, we'll have Salvador Arlandes from Valencia, Spain, and Tufan Tarkan from Istanbul, Turkey. This webinar is organized by the European School of Urology Online with the collaboration of the section of functional urology. And you might see that the section lost an F. Is no longer the section of function and female urology because we understood in the board and with the executive that functional is both for males and females, and we don't need to have the word females in the title of the section. So is now only the European section of functional urology. These are the disclosures of the faculty, mine from Tufan and from Salvador. And this webinar is accredited with one European CME credit, but for that you have to complete the questionnaire and attend after attending the webinar. And this is the schedule. During the next 10 minutes or so, I will try to show to you how important is this problem. Then Salvador Arlandes is going to discuss if the problem is related with surgeries. Are we offering wrong surgeries to the specific patient we have? And which is the rate failure of the surgeries? Is it the same or not? And then Tufan Tarkan is going to address a different aspect, which is the importance of OAB and of underactive bladder in the persistence of medical treatment after BPH surgery. And then we are going to have a clinical case for discussion and to withdraw final conclusions. And so in terms of the size of the problem, well, this is what you can see from a meta-analysis. And in this meta-analysis that actually was used by the EU guidelines, you can see that overall, TURP can improve substantially Qmax. It can reduce by 70% IPSS score, can improve quality of life, reduces by 80% the post-void residual, and has a durable effect. So if we look to this slide, we say, well, if we do a TURP, we have the problem solved. But if we look into this problem in a different way, and that is a Japanese study, on yellow bars, you see voiding symptoms. On green lines bars, you see the storage symptoms. And you can see that symptoms, when analyzed individually, do not improve 100%. The stream is improved in 60% of the patients. Other voiding symptoms improve by 50% in 50% of the patients. But if we move to storage symptoms, we see that they don't improve in more than 40% of the patients overall. Nocturia does not improve in more than 19% of the patients. This is probably the reason why patients still need medical therapy, either 5-alpha reductase inhibitors, alpha blockers, combination, or antimuscarinics. This is in France, data from France, along 6 years of follow-up. And you can see that overall, a very large proportion of patients, if you sum those that are on alpha blockers plus 5-RIs and antimuscarinics, are taking or are persisting in medical therapy. And this is not only a problem in France, it is also a problem in the other side of the Atlantic. Here are the data from Canada, again with alpha blockers, 5-RIs, and anticholinergics or beta-3 agonists now, so it's a more recent study, but the data are very similar. Years after TURP on the horizontal line, and you can see that the proportion of patients that need therapy, if you sum up, is extremely high, and within 5 years, it will be much more than 30 to 40%. Either medication directly to the male LUTS, prostate male LUTS, or to OAB symptoms. One of the reasons, and that will be discussed during the webinar, might be related with the age of the patients we are operating. Now we are operating elderly patients, some of them presenting with long-term catheterization, indwelling catheterization. The prostates tend to be larger. It's interesting that probably because we maintain the medical treatment for longer periods of time, we see that the flow is poor now in our patients, the post-void residual slightly higher, and the symptoms are more intense, at least by the IPSS score. So eventually, are we extending too much our medical treatment? Eventually we are, and we are operating when the bladder is no longer in good conditions. Eventually we might be using treatments that are not correct or adequate for the patient. This is the data from the Rezūm from last year, and you see that within 3 months, half of the patients, the pink bars, had to maintain medical treatment. With time, that percentage decreased gradually, but at 1 year after the Rezūm treatment, about 20% of the patients had to maintain the medical treatment. And if we go for UroLift, that is, of course, a very simple procedure. In this cohort of 200 men, 19, that means 44%, had to continue their medical treatment or had to start a new medical treatment. And if we think that the surgeries are forever, they are not forever. This is from Austria. And after 8 years, 8% of the patients had to repeat TURP or had to repeat the surgery after open prostatectomy. And this is not particularly different from what one can see in France. After 5 years of follow-up, we can see that many patients that had a TURP, the second line from the top, they have to repeat the TURP. And of course, if the patients have the minimal invasive surgeries like incision of the prostate and other surgeries that we do not use now anymore, like microwave therapy or tuna, these patients had to repeat quite a high rate of reinterventions. So I said that I think we have a problem. Our surgeries are not so effective as we could imagine. And the question is it because we are not choosing the surgeries that are the most adequate for our patients, or is just because our patients have other problems like OAB or underactive bladder. So to start by the discussion of the surgeries, and Salvador Arlandis is going to discuss if we are using the right surgeries. So Salvador, please go ahead.
Thank you, Francisco, for inviting me to participate in this webinar. And well, thank you for all the attendants for being here in this webinar. Well, these are some of the points I want to discuss during the next slides. And we just address the point if we are postponing surgeries for too long, that you have suggested before, Francisco. But before, I want to highlight this study. This is a very interesting study from UK that, well, this is from a registry study that shows that including more than 500 patients, most of them operated with monopolar TURP. And what is very interesting is to show that nearly 40% of the patients could not be discharged at the first follow-up, and mainly because of residual symptoms, lower urinary tract symptoms. And the main interventions, second interventions, were due to storage residual lower urinary tract symptoms. That means that it's very well known that even 1/3 of the patients after TURP are dissatisfied with the surgery. That's a very important point. And dissatisfaction comes from the persistence of storage LUTS or voiding LUTS, or both, and maybe, of course, they have influence on the quality of life. Maybe we can use some objective parameters, and we can use like the Wills criteria, while different cutoff points for the IPSS or the Bladder score or the Qmax of post-void residual. But at the end, it's quality of life what is affected. And for sure, there are other factors that influence the results, and acute complications are one of them. For example, need bleeding or urinary tract infections, or long-term side effects like incontinence or sexual dysfunctions or need of retreatment or stenosis. In fact, all of these factors at the end will come with a dissatisfied patient. And if we go too fast choosing our surgeries and making decisions, probably the patient will come too furious or too dissatisfied because of bad decision. So it's very clear that we need to choose the right surgery for the right patient. And it's a very interesting review that the authors say that there is no one-size-fits-all treatment for LUTS due to BPO. And for sure, we need to personalize the treatment based on patient factors or anatomic factors of the prostate, or even values and preferences. For instance, we need to keep in mind the patient factors like age or comorbidity, while the size of a prostate or even the presence of a median lobe are for sure preferences from the patient, like some of them don't want any sexual side effects like ejaculatory dysfunction, or don't want to have a long length of hospital stay, or don't even want to think about the need of retreatment. So there are factors that are part of the decision shared making process. Just some examples that came from this paper, I think very interesting to read. For example, a patient with, an elderly patient and comorbid patient that is very unsafe for any kind of anesthesia. Probably we have to keep this patient on pharmacological therapy only, or move to a minimal invasive surgery treatment. Or those who want more efficacy compared to the pharmacological treatment, but only local anesthesia, probably we can offer Rezūm or UROLift or prostate arterial embolization. For sure, those who want to ensure a long-term efficacy and are not concerned about sexual function, probably you can offer a TURP, classical TURP, or a laser hormone enucleation of the prostate, or photovaporization of the prostate. Even those with high bleeding risk, photoselective vaporization of the prostate, the hormone laser or enucleation are useful, or those who are very concerned about sexual dysfunction, UroLift or Rezūm are options to consider. For sure, those with larger prostates, probably aquablation or green laser, or even hormone enucleation with laser, it's an option. Well, considering the classical ones like open surgery or even robotic or laparoscopic adenomectomy. In any case, we have to keep in mind the patient preferences, because if not, we can have some troubles. It's a very interesting American study that shows and highlights the discrepancy between patient and urologist priorities. For example, this is a survey among patients. And if you look at the graph in the red bar highlights the importance of the patients. They give very importance to complication risk. And if we compare older versus younger patients, for sure, the older patients give more importance to complication risk compared to other factors, like, for instance, for a clinician, probably long-term efficacy is a very important point. So we need to keep in mind patient preferences. And are the new surgeries less effective? Well, the classical ones show some low efficacy at the long term. For instance, this is a German study comparing, including more than 43,000 patients. And as you can see in the graph, in the upper part is the open surgery, in the lower part, the lower graph, is just the photoselective vaporization of the prostate, and very similar are the enucleation with hormone laser and the TURP. So as you can see, probably the open surgery gives the better long-term efficacy compared with the other ones, but all of them has need of retreatment and at the long-term follow-up. In this case, 5 years. And what about the minimal invasive surgery therapies? Well, probably the most recognized in the guidelines is the prostatic urethral lift, as you can see by the level of evidence and recommendation. But of course, the patient should be informed about the long-term effects, even the risk of retreatment. And very recently, there is a nice systematic review that shows and highlights a 6% of need of retreatment per year, including removals of the device. So it's a considerable number. If we compare with other minimal invasive treatment, for instance, the Rezūm is 4% at 4 years follow-up. The iTind is 10% at 2 years. Embolization is 20% even in the first year. And the Aquablation is 4% at 5 years. It's not so bad, but we have to keep in mind these numbers. But we can predict which patient will need a second treatment after TURP. Well, it's a nice Italian study that they have a 14% rate of second TURP. And when they analyze the different factors that influence the need of retreatment, the most important is the need of medical treatment. So those patients, you can see in the Kaplan-Meier curves. So that means that if your patient needs to take medication because of persistent LUTS, probably the patient at the end will need a second surgery in this study. And what happens with those patients who do not respond to TURP? This interesting Swedish study that, with these numbers, those non-responders are those with urinary irritation or lower urinary tract symptoms. And at the end of the follow-up, most of them are with an Welling catheter or with clean intermittent catheterization. But the most important part is that only 3 patients of this cohort of patients undergone urodynamic study. And the same authors advise us, saying that to prevent unnecessary reduced surgery with potential side effects, for sure, urodynamic studies are essential. But do we follow this advice? Well, we have to recognize that not always. This is a very interesting urodynamic survey among urologists, and they just depict 4 scenarios. From the scenario 1, the Detrusor activity with 1 liter of post-void residual and incomplete voiding, to scenario 4, frequency urgency only with high pressure, low flow avoiding on urodynamic study. And they ask if they will offer TURP to these cases, and the chance of voiding they think this patient will have after TURP. And as you can see, the numbers offering TURP are very high. Even in the worst scenario is scenario 1. And the chance of voiding is hardly superior to 50%. That means even they think that in the scenario 4, frequency urgency with high pressure, the risk of your urgency urinary incontinence is high, 1/3. But even in those cases, we choose TURP. So that means that maybe we don't follow the results of the urodynamic or don't rely a lot in urodynamics. And about the question of if we are delaying too long the BPO surgeries, well, this is the normal pathocronia and evolution of a prolonged bladder outlet obstruction. We know there's a hypertrophic compensation and probably the Detrusor activity, and at the end, the Detrusor underactivity. We know that this is a continuous process, and maybe in the meantime there is some point the Detrusor activity and the Detrusor underactivity coexist, and this is a problem to solve the symptoms. And well, as we know, because of the Chancellor theory was proposed, and prolonged overactive bladder and the Detrusor overactivity, maybe in the meantime we'll have a coexistence of both, but at the end there is exhausting the Detrusor that will lead to the Detrusor underactivity. This means that it's a situation that is difficult to resolve only with TURP. And an important point, those patients who are in acute urinary intention and who present to TURP coming from acute urinary intention show worse results. Even those patients with more than 1 and 2 preoperative catheterization due to acute urinary intention show a higher chance, even the double chance, of requiring any reoperation or need of catheterization after TURP. That means bad result of the surgery. And of course, if you wait too long from the acute urinary intention, the first rotation with catheterization, to the TURP, the longer the period, the worse the results. And at the end, this is a classical one that shows that in the last 2 decades in this center, they show that the number of patients going to TURP were lower, and the number of patients under long-term medical treatment were higher. And those patients show in the last decades more preoperative progression events like acute urinary retention or chronic urinary retention, poorer immediate short-term results like discharging with a bladder catheter because a retention after the TURP, and higher rate of postoperative complication. So to conclude, my message is that to show better results, probably we need to solve the bladder outlet obstruction for sure. And even long-term medical treatment and long-term bladder outlet obstruction will lead to probably at the end an underactive bladder and overactive coexistence. And probably even these entities may be absolutely different and not linked to bladder outlet obstruction. Well, I think that my friend Tufan Tarjan will develop more on this point. For sure, we need to choose the right surgery for the right patient, but the most important part, we need to listen to our patient, to discuss with him about the preferences of the treatment, just to make a good shared decision making process. Thank you so much.
Thank you, Salvador. Thank you for your clear presentation. And so I think it is quite obvious that one of the reasons the symptoms might persist is, of course, the duration of the disease, eventually the prolongation, the excessive prolongation of medical therapy, and an incorrect decision of the surgery because it was not discussed previously with our patients. But you also mentioned, in fact, the other problem is OEB and underactive bladder, and now too fun. It will be your turn to explain to us and to our audience how OAB and underactive bladder can influence medical treatment after BPH surgery.
Thank you very much, dear Francisco, dear Salva. It's a great pleasure for me to be here in this webinar, thanks to European School of Urology and the EAU section of Functional Urology for the kind invitation. I think you all see my slides. Yeah. And also I would like to welcome, I think we have like more than 170 people listening to us. Good evening or good day to everybody. So what we have learned from the lectures of Professor Cruz and Arlandis is that bladder outflow resistance reduction surgery does not always cure male LUTS, and additional treatments will be required in a significant ratio of patients after surgery. You will see this abbreviation many times during my presentation, which is B or RRS. This includes actually all kind of surgeries and interventions that Salvador has clearly explained us. It's not only prostatectomy, but includes also the new techniques, the minimal invasive surgical techniques that target to decrease the bladder outflow resistance. So let's summarize what we have so far in our hands and how we are dealing with our patients who are coming to us with a complaint of bothersome lower urinary tract symptoms. Well, the pre-surgical clinical and urodynamic picture includes these three famous rings that you all are familiar with. Male lower urinary tract symptoms are assumed actually to be due to obstruction, but unfortunately not all patients undergo invasive urodynamic studies to prove obstruction. So in many cases, our treatment starts in an empirical way. These lower urinary tract symptoms include both storage phase symptoms and emptying phase symptoms, and pre-surgical urodynamics, if performed, can reveal Detrusor overactivity in a significant amount of patients, and also Detrusor underactivity in another group of patients. Again, invasive urodynamic studies are today only performed for a specific group of patients with male LUTS. And if they are diagnosed, we know that both DO and Detrusor underactivity are markers of poor treatment outcome, whatever you choose, medical treatment or surgical treatment of any type. And we also know that their coexistence is the worst prognostic outcome, as described by Yalla and Resnick. Many years ago, the Detrusor hyperactivity with impaired contractility is the worst outcome for TURP, which is associated with a very high prevalence of urinary incontinence after surgery. So our initial treatment includes usually medical treatment and conservative treatment, and non-responders to this initial treatment are offered different types of prostatectomy surgeries. And we have learned from Salvador and from Francisco that we see after the surgery a significant group of patients, again, unfortunately with persistent LUTS. And then urodynamic studies, invasive urodynamic studies are usually performed, which reveal persistent obstruction in a group of patients. If we diagnose it, we may handle these patients with, in mild cases, maybe still with alpha blockers, but the radical solution for that is a re-intervention, which targets resolving the outlet obstruction completely. Then we see some patients with persisting overactive bladder. Patients, actually 1/3 of patients diagnosed with overactive bladder symptoms will persist to have these symptoms after surgery. And then we have the group of patients with Detrusor underactivity, which is actually the main reason for poor voiding after any kind of outlet surgery. And this is maybe the group that we don't have much chances to help the patient with, except some conservative measures. So by just looking to this figure, I think many of us have created those questions in their minds. First of all, why some men with obstruction develop storage symptoms and some do not? Why does Detrusor overactivity or overactive bladder symptoms resolve in some patients after surgery and in some does not? And the same questions are also valid for Detrusor underactivity and underactive bladder symptoms. And actually the answers to our questions are hidden behind the multifactorial etiology of male LUTS. We know aging is the strongest denominator of male LUTS. And the link between aging and male LUTS can be explained by different theories, where pelvic ischemia appears to be, for example, one of the strongest ones. Pelvic ischemia by causing arterial insufficiency and hypoxia in bladder tissue is shown in animal models, and also there is some evidence in humans that it causes increased bladder smooth muscle contractions leading to Detrusor overactivity. Meanwhile, pelvic ischemia also leads to promotion of prostatic contractile activity, increasing the urinary outflow resistance. And we also know that LUTS is associated with erectile dysfunction in many patients. And ischemia of the pelvis is also a good theory to explain why ED and LUTS can be seen together. It's not only aging, it's not only ischemia. There are other factors that influence the picture. For example, comorbidities of the patient, the obesity, all the metabolic syndrome, domains and smoking, etc., plus the bad bladder habits of the patient, whether the patient has the habit of postponing urine or not during his life, the dietary habits, etc., actually are big holes, big gaps that we need to explain, and all come together and alter the functional, morphological, and neurogenic properties of the lower urinary tract. So in summary, we don't have a size that fits everybody in male LUTS. We have a multifactorial etiology, we have different pathophysiologies, and unfortunately, we offer surgeries to our patients empirically in most of the cases. We know that 75% of men actually report overactive bladder symptoms in the presence of bladder outlet obstruction. And however, the etiological relationship between these two entities still remains unclear. We can speculate that obstruction leads to overactive bladder symptoms in a certain group of patients because OAB symptoms resolve in 2/3 of patients after a successful outlet surgery. However, in 1/3 of patients, still they persist. We also know from Abrams' study coming from actually 1979 that the presence of DO on preoperative urodynamic studies can persist and lead to ongoing storage LUTS following a successful surgery. More than half of the patients in their series planned for bladder outlet surgery had Detrusor overactivity, and this Detrusor overactivity persisted in approximately 1/3 to 1/2 of patients post-surgery. And in addition, urgency and urge urinary incontinence also persisted in 40% and 33% of this group, respectively. So we know from many years, actually, the OAB symptoms actually respond in a ratio to a successful surgery, but about 1/3 of them still remain after surgery. A recent systematic review assessed 30 studies in this manner. They found a huge range between 29% and 100%, showing improvement of symptoms in patients with preoperative Detrusor overactivity. Some studies showed improvement after surgery, some did not. But in general, as an average, Detrusor overactivity resolved post-surgery in a range between 57 to 83% of patients. So at least we might say that In that patient group, the obstruction was the cause of Detrusor overactivity since it is resolved after a successful surgery. Here, the literature also tells us about the factors associated with poor surgical outcomes. For example, absence of obstruction on preoperative urodynamics, or the type of the bladder outlet surgery, low maximum cystometric capacity, early and high amplitude Detrusor overactivity, or terminal Detrusor overactivity and older age were found to be associated with poor surgical outcome in that systematic review. If we analyze the upstream trial and its association of findings with Detrusor overactivity, we see that in general, surgery was more beneficial in those patients with higher symptom scores, with ages younger than 74, with a Qmax less than 10, with BOI more than 48 and BCI 123. And interestingly, the presence of DO weakened the relationship between these indices and the change in IPSS. And where DO was absent, the indices were better predictors of outcome with higher levels, resulting in more successful surgery. So DO was here, again, a factor which was badly affecting the outcome of surgery. The question, can we predict which patients will present resolution of Detrusor overactivity after TURP? I think is the main question that we should ask, and Antunes and Associates tried to answer this question in their series published in 2014. Just to summarize their findings, they found that older patients with high amplitude early Detrusor overactivity and a maximum cystometric capacity of less than 250 milliliters had a chance of persistent Detrusor overactivity after surgery with a rate of 83%. So if these urodynamic findings are seen together in a pre-operative urodynamic study in a patient, then you can estimate that in 83% of cases, Detrusor overactivity will still persist after surgery. So what is the role of uncorrected obstruction or Detrusor underactivity in persistent LUTS? There are still a group of patients who are still obstructed after the surgery, unfortunately, and this rate is not negligible. It is almost 1/3 of patients that we operate in a series published by Koa and Associates. The other urodynamic findings were Detrusor overactivity, Detrusor underactivity, and their coexistence, and the authors found a normal video urodynamics only in 9% of their cases. So the majority of their cases with persistent LUTS after TURP had a urodynamic abnormality. However, these patients did not have pre-surgical urodynamic studies. Therefore, it was not possible to predict whether these symptoms or findings were persistent or newly developed. How do we treat our storage symptoms following prostate or bladder outlet surgery? Well, the therapeutic options are almost the same as in surgery naive patients, like we proceed with idiopathic overactive bladder, including lifestyle modifications, pelvic floor physical therapies, and bladder training. And then they continue with medical treatment, including antimuscarinics and beta-3 adrenergic agonists, and followed by, for refractory cases, intravesical botulinum toxin and sacral neuromodulation. And it's always to remember that the residual obstruction is the first thing that we have to exclude in that patient group. Unfortunately, there is a lack of studies specifically designed for that patient group, but still post-hoc analysis suggests that both antimuscarinics and beta-3 agonists are effective, and they can also be used in combination with an alpha blocker. And both antimuscarinics and birabegron are safe, even in men who have obstruction or underactivity, but still we need a higher level of evidence to make strong recommendations. So in refractory cases, we may proceed with intravesical onobotulinum toxin. But again, unfortunately, there is not a high level of evidence. There's a lack of randomized clinical trials in the literature. In one of the few studies by Bells and Associates from the Maastricht group, they divided their patients into 3 groups as the ones previously undergone TURP, the ones who underwent radical prostatectomy, and those without a prior history of surgery. And all these patients underwent botulinum neurotoxin injections. And it was to note that the increase in the residual urine was much higher in patients without any prostate surgery compared to the prostatectomy groups. And in parallel to that, the clean intermittent catheterization rates were much higher, reaching 28% in the surgery-naive groups compared to the prostatectomy group. So botulinum neurotoxin injection appeared to be a safe procedure, especially after prostatectomy, after obstruction is resolved in that patient group compared to non-surgical group. And then finally, sacral neuromodulation can be another salvage method for us. SNM is effective in men, we know. However, male gender, we also know that is a marker for poorer outcome when compared to the female population. Again, unfortunately, no studies have specifically examined the outcome of that patient group with exclusive storage symptoms with a prior history of prostatic surgery. However, in few studies, a history of TURP was not associated with poorer outcomes as shown by Stansland and Associates. However, the authors have also found that if a male patient has a first urge at less than 100 milliliters during filling, he is highly unlikely to have a successful sacral neuromodulation trial. So in conclusion, I think we all agree and we all very well learned that storage and voiding lower urinary tract symptoms can persist after any type of surgery, aiming to decrease the outlet resistance in male patients with LUTS. Unfortunately, symptoms alone are unreliable in predicting urodynamic findings with respect to obstruction, NDO, and Detrusor underactivity after any type of surgery. In that patient group after surgery, urodynamic studies is the key to assessment for those groups with bothersome LUTS. And further treatment in that patient group based on postoperative urodynamic studies findings, depending on whether the patient has obstruction or DO or Detrusor underactivity. We need further research with large clinical trials where urodynamics is utilized not only after surgery, but also prior to surgery in order to be able to understand the pathophysiology of LUTS and also to reach a better counseling chance for our patients prior to surgery and discuss with them the possible complications and outcome of surgery. Well, thank you very much for your attention.
You're mute.
Thank you, Tufan, for your very clear presentation. And so, before discussing the clinical case, I think I can summarize that the first thing we need to do to obtain a good result in terms of surgery is to study very well our patients. Which type of symptoms do they have? Eventually, do they have the Detrusor overactivity and how severe it is? Because in those cases, the results can be problematic in terms of persistence of medical treatment. We need to counsel patients, and that is very important. We need to have functional urologists with good skills, because when surgery is not good for all patients, and so we have to select the right surgery for the right patient, in terms of the size, in terms of the size of the middle lobe. I think one point that you mentioned, Tufan, I think it is extremely interesting, is the importance of the bladder capacity, because eventually, due to a very prolonged bladder outlet obstruction, the bladder might lose compliance, and once the compliance is lost, the capacity is lost, and it will be difficult to obtain good results in our patients. And with age, we have other problems like the Detrusor underactivity. So I think we have to be extremely careful when analyzing our patients, not prolonging excessively the medical treatment, but also not proposing the surgery as soon as we see our patients. So this balance is critical for functional urologists and requires experience, if I can say. I'm going now to share the screen again, and this is a real case we had. A man, 73 years old, that had a strong severe LUTS, voiding and storage, total IPSS of 26. He was diabetic on metformin and on gliflozin. He was diabetic for 20 years. The prostate volume was 50 mL. The flow was very low, 8 mL per second. The post-void residual was high. And 1 year ago, we offered him a TURP, and he accepted quite well, because he was on alpha blockers and the results were very poor, and he was not very interested in receiving 5-alpha reductase inhibitors, because of the sexual problems that could be related with these drugs, and could increase the sexual problems he had already due to diabetes. Any problem until now from your side, Salvador, or from Tufan? This is a classical case.
Yeah, it's a classical case. I think that the patient has severe symptoms, and probably he needs something more than only medical treatment. But there is the only point that I'm a little bit worried is, two. In fact, one, diabetes mellitus is always a confounding factor because of neurogenic. It is a very long evolution of this disease. And the second part is the bladder voiding efficiency that seems low, very low, because at the end the bladder capacity is 500 and the post-void residual is very high.
So you would suggest that we should probably have done at this moment an urodynamic study before doing the TURP, at least for canceling the patient.
Yeah, I would do that. I would do that, Francisco. There's a huge PVR here. It's also indicated by the, I think, EAU guideline here. This high PVR actually necessitates invasive urodynamic study. I also was wondering actually about the shape of the free flow. I don't think that this gentleman voids with a very nice bell-shaped curve. This 150 milliliter. So I think, I agree with Salvador. So this is a dangerous case.
This is a dangerous case.
But yeah. So I want just to underline that for sure we are not giving the message that every patient needs urodynamics before BPH surgery. But there is some red flags that we have to keep in mind, and while EAU guidelines give us some clues about these red flags during many years in a very nice table, and we have applied them. And I think that we should follow that red flags more frequent than we do usually.
Yeah, I totally agree. I think we should have investigated this patient a little bit more, but I think at that time we just interpreted this data as obstruction, and so we offered him a TURP. But he was not happy because 3 months later he came back complaining of weak and intermittent flow. And high frequency and high nocturia. And what would you do at this moment, 3 months after TURP?
Well, you first. I start before, so.
Yeah, please go ahead. Do you want me to answer? Yeah, sure. Yeah. So I would like to see if you, I don't know if you did it, but a bladder diary, Francisco, in that case, might be helpful here. And then I may go, actually, since this person had a surgery, I would go for a cystoscopy here. To see whether he had any stricture or any other problem. So I wanted to see his urethra in that case, and probably, follow with urodynamic studies.
And for sure, I would like to have a second uroflowmetry just to be sure that the patient, what is telling the patient is really a weak flow objectively.
In fact, and this is also important for our audience, Tufan, you are quite right, but 3 months after the surgery or 4 months after the surgery, we thought that eventually a free flow would be enough, but the flow was not particularly good. The post-void residual had decreased, the urine was sterile, and so we decided to give him a chance with tamsulosin 0.4 milligrams per day. Not completely wrong. Would you agree? And we make
I mean, this is actually the normal pattern how we always deal with these patients.
Is the normal pathway.
Yeah, just can you please remind me if he was already on an alpha blocker before the treatment, before surgery?
He was an alpha blocker.
Yeah.
And so the probability of improving very much with a second alpha blocker would be low. But
but I agree.
We decided because it was too close to the surgery.
But Francisco, just sorry for the question, but what do you do with the storage symptoms that are very bothersome? And I don't know if you decide to treat them or not, or the residual you're a little bit afraid and prefer not to give some.
Actually, we thought that this could be related with poor emptying for some reason, and so that's the reason why we thought that the alpha blocker could help a little bit more in this situation.
Yeah, actually, I mean, sorry. It is always easy, to make retrospective analysis and retrospective comments on that. But really, this is a very important real life case, Francisco. This is how it goes in many cases. There are, of course, European guideline recommendations, but in the daily life, in clinical practice, we may miss them because there's so much really influence from media, from everything on the patient. And the patient usually comes to us with their own diagnosis. Every problem of his symptom is related to prostate. This is what they think. And I think this is a really very common situation in the real life.
Also, we thought that it would be unlikely to have a residual tissue in the urethra because the TUR went quite well. So we were a little bit puzzled by this situation, and that's why also, he arrived and had no bladder diary. But then we asked for the bladder diary, and in September he came back under tamsulosin. The symptoms were very similar. The bladder diary confirms the frequency and nocturia. The flow is still low, and the post-void residual is high. So, what would you like to know at this moment?
Francisco, I understand that from the bladder diary you have ruled out nocturnal polyuria, that it's a very frequent cause of nocturia in elderly patients.
Yeah, right.
Okay, so
but that is an important point for our audience, because nocturnal polyuria could be in fact a problem. Let me see, we had one question. And so, like Tufan said, we asked for an erythrocystoscopy, which was normal. The urethra had a good caliber, no strictures. The prostatic urethra was well open, no residual tissue, and the bladder neck was open. So, Salvador, at this moment, what would you like to do?
Yeah, for sure. I don't have many options, so I will move to urodynamic study for sure, because I really I have a treatment failure. There is no anatomical reason for that voiding symptoms. So I need to clarify why this patient is still having symptoms. And I don't have nocturnal polyuria. I don't have anatomical structure that could be the cause of obstruction. So I need to rule out functional causes of obstruction or any other causes of voiding dysfunction, like the Detrusor underactivity or the Detrusor overactivity for the storage symptoms, anything else.
And so here you have what you would like to have the Urodynamics study. On the left side, the filling phase. On the right side, the voiding phase. You see a very large capacity without the Detrusor overactivity. So no contractions until 700 mL of bladder capacity, so a huge bladder capacity. And during the voiding phase, you can see that the patient is straining. The maximal Detrusor pressure was quite low, and the flow was really intermittent and very low. After a TURP, only 11 mL per second is a very poor flow. Bladder contractility index indicates clearly that there is no obstruction according to the ICS normogram, and the bladder contractility index, the bladder outlet obstruction index, and the bladder contractility index indicates poor contractility, so it's below 100. So, Tufan, would you like to comment this case?
Yeah, it's really interesting. As I have tried to mention in my talk, it's sometimes good to have a pre-surgery urodynamic study in order to have a comparison. We see that actually not much has changed in the symptoms of the patient after surgery, also in the uroflowmetry findings of this patient. But I cannot tell precisely if anything has changed in terms of obstruction or not. Maybe the patient had a higher bladder outflow obstruction index prior to surgery. Maybe that, I don't know. But what we have as of now in our hands is an unobstructed pressure flow study with a low bladder contractility index. So certainly now we understand that why alpha blockers do not help in that patient, why the surgery probably did not help for the patient. So this is clearly a Detrusor underactivity case, and we have to treat the patient accordingly.
We offered him more to try double or triple voidings in order to empty as much as possible the bladder. Would you agree with this situation?
Yes, I certainly agree. Actually, there is no cutoff level of residual urine in that patient group, which tells us to start clean intermittent catheterization. It completely depends on the symptoms and complications of the patient, on the border of the symptom, whether the patient develops UTIs or not. So I agree with your first choice, Francisco.
Yeah, because to start immediately with CIC, the problem is the risk of bacteriuria and it is more invasive. Would you agree, Salvador?
Yeah, for sure. I want to comment that some attendants may think that having a 700 milliliters of bladder cystometric capacity is so high that why this patient has a frequency. But the reason is that probably from the bladder diaries, the functional bladder capacity, the real functional bladder capacity is much lower because of the high residual volume. So the patient is always with a high residual volume, and that's why the bladder capacity reaches the top, the higher number in a short time. So I think that timely voiding is very important, and to make a double and triple voiding, because some patients, even diabetic patients, may develop a long-term some sensation impairment, and can have even overflow urinary incontinence. But I agree with you. And on the other hand, sometimes if you start self-catheterization, depending on the kind of TURP that you have done, sometimes it's a little bit difficult because of the cell resected. So sometimes it's not so easy.
Mm-hmm. So I choose this case because clearly this will be very common in the practice of all of us, and will be very, very common in many of our colleagues that are listening to us. And clearly what we need to investigate before surgery is if the patient is at risk of having underactive bladder or Detrusor overactivity after before the surgery. In this case, if we knew in advance that this patient had Detrusor underactivity due to his diabetic mellitus problem, this patient could at least be well informed about the risk of maintaining the symptoms even without obstruction, after the surgery. Would you like to comment this, let's say, overview of how to handle the symptoms after a TURP? How should we handle the symptoms for a patient that after prostate surgery still has symptoms? Would you like to start by cystoscopy? Would you like to start by urodynamic for the Detrusor overactivity, the Detrusor underactivity? What is your opinion, Salvador?
I first just use the clinical history about the symptoms, which symptoms are the most predominant, storage voiding, for sure, and an uroflowmetry, just to have an objective measurement of the minimal functional situation of the patient after that. If I find a very bad uroflowmetry, probably even before urodynamic study, I like to rule out any stenosis or any cervical stenosis or bladder neck stenosis or residual tissue, very clear residual tissue. And probably I reserve urodynamic study to the third step. I don't go straight to the urodynamic study usually.
Tufan, you agree?
Yeah, of course I agree. I mean, it's always wise to start with non-invasive studies. Of course, it depends from patient to patient. It changes from patient to patient. If you have a patient who was clearly obstructed prior to surgery, then you may maybe think more on doing a cystoscopy to rule out a case. But still, I wouldn't do any surgery on any patient. I mean, targeting the outlet before repeating the urodynamic study and before proving the outlet obstruction urodynamically.
There is one question that was made by one of our attendees, Gilles. He asked us about the importance of the size of the middle lobe, the intravesical prostatic protrusion. Do you use this criteria for indicating surgery? Do you use it in clinical practice? Do you think it has practical value? Or you agree with guidelines that we should not use, at least regularly, these criteria?
Well, I personally, in our department, we measure the protrusion of the median lobe because, well, we have made internal evaluation. I have publicated the results many years ago that we have a cutoff point of 10 millimeters, 1 centimeter, related to urodynamic obstruction. So I think that it's useful. Probably if it's easy to measure, I don't find why not to measure and to keep that data on your armamentarium diagnostic tools.
Mm. We have another interesting question that entered quite recently, just a few moments ago. Let's imagine that we had performed the urodynamic study in this man before the surgery, before the TURP. He was obstructed, but he had a large capacity, and so he also had an underactive Detrusor. What would you do? How would you inform this patient about the success of TURP? I don't know, Tufan or Salvador or both?
This for Tufan. It's more difficult. So for Tufan.
Yeah, my pleasure. Yeah, this is an interesting case scenario. A huge bladder capacity with obstruction. And symptoms. If the patient is obstructed in urodynamic studies, I would offer him certainly a surgery, a prostate surgery. But I'm not sure that this was a possible scenario for the patient that you have presented, Francisco. Most probably the patient's obstruction index was at best in the equivocal area, if I have to speculate something. Before surgery, rather being clearly obstructed. But if the patient is obstructed, plus made LUTS, I think we can offer. We shouldn't forget that even in patients with, retention, and who couldn't void during the urodynamic study, there is about 30% of chance after a good enucleation for voiding. So it doesn't mean that we shouldn't offer, prostatectomy surgery, prostatectomy for these patients. Of course, the urinary retention is a completely different area because we don't know if the patient is obstructed or not, because we cannot perform pressure flow studies in that patient group. But still, I think if I understand the question correctly, if the patient is obstructed, yes, prostatectomy.
Yes, I totally agree with you. And for our audience, I think the important point in such a case is to do a correct TURP to remove all the tissue. And if the prostate is large or is very large, and if you are not sure if you are able to do the resection completely, it's better probably to go for an enucleation, because really the best solution for such a patient is to reduce as much as possible the resistance of the urethra. I don't know if you have any comment, Salvador, on this.
Well, I agree absolutely with you. For sure, if you have some Detrusor contraction reserve, just to ensure that the patient will be able to void, I think that you should perform the surgery. But for sure, this is a continuous. That's why the patients in the equivocal zone, some of them are able to void, and others not. So the patient needs to be informed about that situation, because at the end, you really don't know. But for sure, if the patient, but has a BCI very low, probably the patient will not be able to void, even having some or even having obstruction or coming from a prolonged obstruction. So I think that it's a difficult point. We don't have very clear cutoff points, even from the upstream study. It's very well designed, but we need to manage all this data to inform the patient about the risks of the surgery and the benefits, and take a shared-made decision.
Well, I think it is time now to finish this webinar. I would like to send first to our audience. We had almost 200 attendees with us during this last hour. They made a lot of questions, and we will try to answer them by writing. We don't have time to answer them orally at this moment, but I think it is important really to understand that patients that have or men that have lower urinary tract symptoms, they might maintain those lower urinary tract symptoms after prostate surgery, and that should be part of the information we have to give to our patients, and particularly those patients that have higher risk. That means patients that are elderly, that were long time catheterized, long time on medical treatment, and that have symptoms very suggestive of Detrusor overactivity or Detrusor underactivity. And of course, I would like to thank Salvador and Tufan for your fantastic presentations and for keeping these webinars alive. Thank you very much.
Thank you.
If we don't see before, we will see each other in Paris for sure.
For sure.
Thank you.
Thank you very much and thank you for the technical support.
Thank you.